Hi everyone. So my name is Shoaib Hussain. I'm a surgical trainee in Oxford. I'm presenting our preliminary findings along with Dr. Soren Iversen and Dr. Hussam al-Nahas. We have evaluated elements of surgical capacity in northwest Syria. This has been a massive project involving several Syrian organizations with support from R4H-SSS, King's College London, and Oxford University.
So just giving a brief introduction that led us to this project. So some of you may be aware in 2015, the World Health Assembly adopted a resolution that effectively said that surgical and anesthetic care should be components of universal healthcare, recognizing it as part and parcel of the overall healthcare provided. In 2015, same year, the Lancet Commission on Global Surgery was published. And again, this was quite an important benchmark in terms of useful minimum targets to achieve in terms of safe preoperative care. But very importantly, they excluded the humanitarian setting because the needs and the circumstances different from stable settings. But still, they stipulated many of these would be maybe relevant in a variety of settings, but would need further review. Interestingly, again, 2015, a very important year, USSM provided the first health facility survey of two, and effectively both of these surveys found that surgical provision was affected by staffing shortages and faulty equipment. But this provided a perfect opportunity to explore if the Lancet Commission findings were relevant in conflict settings. As Shoaib mentioned, through collaboration, we've now done a repeat survey and exploratory workshop to look specifically at the surgical and anesthetic capacity, so expanding the survey slightly, but also to acknowledge COVID-19 and the effects it may have had, and then some elements on safety and protection. Okay, thank you. Next.
So to make sure that you get into the data and the findings that we had, I'm going to really set the stage for the method that we used. And we started by doing a health facility mapping and like list all the hospitals and medical facilities that are providing surgical services in Idlib, northern and western Aleppo by support from or supported by health directorates. We also used a modified version of the previous USAM surveillance data collection tool, and we used COBA Toolbox to collect the data. We used both qualitative and quantitative methods. The survey was conducted in person, which is one of the strengths of the study. Online surveys were collected only if it's dangerous for data collectors to go on field and collect these information. And the tool was enormous with more than 600 questions. And when doing the analysis, it was more than 800 variables. We also conducted a workshop with surgical staff by Arabic English speaking researcher to get their perspective and to support the quantitative data. The quantitative data analysis was done by Excel for data management, and then SPSS and Stata for the quantitative data analysis. We had the ethical approval from King's College London, and we also received approval from Idlib Health Directorate and got permissions from all NGOs that are supporting medical facilities. So this is a comparison between the outcomes in the survey in 2016 and 2021. And as you can see, the coverage of the survey really shrank in 2021 after the change in the controlled areas and availability and accessibility to data. For our survey in 2021, we received 50 out of 58 response from health facilities providing surgeries with 82.4% response rate. The hospitals that rejected to or could not participate were 8 hospitals, and 5 of them were in Turkish controlled areas, and 3 of them were in opposition controlled areas but needed additional permissions that were beyond our control. So here's a zoom in on our findings from the current survey. As you can see, the red areas really provide, we have the full picture with all hospitals participating, and the gray areas were Turkish controlled areas where we could not secure like agreement or a permission to collect the data. We also use the ACU data on populations, and this one was published on September 2021 to build some basic health indicators.
So just to, as Hussain mentioned, there's a lot of data, and we've tried to pick out some of the key ones just for this preliminary review. So in terms of the health facilities, we found that in 2021, 10 of the 48 or 50 that participated were purpose-built hospitals. The remainder were reconditioned schools and public buildings and caves for that. And bear in mind, the 2016 geographical area was different. We tried to focus in on the same region or the same districts, and for comparison, it was 28% then that were purpose-built hospitals. So part of the difference between the two could be the geographical areas, but it could also be, as been mentioned in previous presentations, and as all you're aware, the attacks on healthcare infrastructure. In terms of the, thank you. So in terms of the number of facilities without real protection, we found that the vast majority, so 81%, did not have any real protection in terms of external attacks. Looking at hospital beds per 10,000 population, this is a WHO metric. And we know that for the regional, it's approximated between 14 to 15 the hospital beds per 10,000 population. We found in this region that was surveyed, it was 1.1 to 6.9. And the same goes for ICU beds. It's a bit of a peculiar metric and varies greatly across the world. We have in Germany it's 48, while in Sweden it's 5. And here we found that the main finding really was around the fact that 65% of the health facilities did not have any ICU beds at all. In terms of the operating theatres per 100,000 population, this is pretty much true to the regional average, around 4. And this is data that's similar from 2010. And we found that actually there's quite a large proportion of available operating theatres across the region.
So when assessing surgical provision, we used a composite of the WHO situational analysis tool for emergency essential surgical care, as well as a consensus framework developed by the Stanford Humanitarian Surgical Response and Conflict Working Group. Now, these are 44 procedures, but what we focused on for the purposes of this presentation are 3 bellwether procedures. These were developed by the Lancet Commission, and essentially, if a facility can perform a laparotomy, manage open fractures, and perform a cesarean section, that's a pretty good indicator that those facilities will function at a level of complexity that enables the delivery of other related surgical care. An important caveat is that this was developed in stable settings and not really applicable to necessarily conflict settings. So on a preliminary survey of our data, we can see that of all the hospitals that were surveyed, only 10% can perform these 3 procedures, the bellwether operations. And you can see on the right with the bar chart that there is significant variability in terms of essentially hospitals being able to provide some of those procedures, but not all. What's quite striking is that when you break down the bellwether procedures, over half of the surveyed hospitals are unable to manage an open fracture, for instance, which is significant in the context of a war or conflict setting. We also noted that hospitals are fragmented by specialty. So for instance, 17 hospitals in our survey population only focus on maternity and childcare, and only 14 perform general operations. And of those 14, only 5 can perform these bellwether procedures, for example. Another important point that we discovered is, well, we evaluated reasons for referral. No surveyed hospital was able to perform the 44 procedures that I've mentioned before. In total, about 2,112 procedures could be referred for, but there's an important caveat that this was not mandatory data in the survey. And so some hospitals referred without providing us the reasons of why they referred, whereas others gave reasons but didn't indicate that they had referred patients on. About 38% of surveyed procedures were referred. And when we look at the reasons for referral, which was available for about 628 procedures, about 97% of all referrals were because of a lack of supplies and drugs. But there's also a skills shortage. 89% of all referrals were because of lack of skills, and less than 1% of referrals were because of non-functional equipment. There were some important trends in terms of most referred procedures. So on the bottom with the pie charts, you can see that many hospitals were unable to perform, for example, enucleation, spinal surgery, and neonatal surgery and refer these on. But other data also shows that, for instance, over 70% of hospitals could not manage burns, which is significant in a conflict setting.
So just looking briefly at a couple of proxies for anesthesia provision. So I'll look at two, which is looking at the workforce and then also on the specific equipment. So on workforce, there was data showing that anesthesiologists, so physician anesthesia providers, if you're from 4 and more per 100,000 population, the maternal mortality ratio drops profoundly, and this is used as a proxy for the Lancet Commission on Global Surgery. And we find that across the districts, we're not getting close to the 4, and in Ariha there are no physician anesthesiologists. However, if we acknowledge the fact that there are multiple certified anesthesia providers through the presence of the anesthesia technicians, all of a sudden the numbers much improve, and this is something that's worth exploring in more detail, and is something that's increasingly in the global surgery community being explored in more detail, the relevance and presence and acknowledgement of the non-physician providers of anesthesia. Next slide. So in terms of the proxy for equipment, I've used the pulse oximeter, and again, this is something that has been explored for the Lancet Commission, but in general, looking at global trends around safety of anesthesia as a proxy for safe anesthesia. Across the surveyed hospitals, we found that 66%, so 2/3 of the hospitals, health facilities rather, they were able to provide pulse oximetry in theatre. Another 15 hospitals, so nearly a third, had it available in the health facility, but they said that they were not normally made available for theatre. And there was one hospital that did not have pulse oximeters, full stop. Important to acknowledge is also the fact that they don't always work. And we found that I think 16% of the available pulse oximeters were not actually functioning. And this is something that we'll be exploring in more detail around the equipment that we've surveyed, the fact that biomedical engineering and availability of repairs might be an issue. We also looked a little bit at the workforce, and this is again using the Lancet Commission metric of the SAO, so the surgeon, anaesthetist, and obstetrician per 100,000 population. And here they found, again, using the maternal mortality ratio as the proxy for surgical care as a whole, when the numbers got between 10 and 20, the numbers vastly improved, and above 20, it was statically improved. And again, we find that although Idlib gets up above 10, the numbers overall are not approximating what has been signified in low resource settings, but not in conflict necessarily, as safe numbers. The nurse to bed ratio, again, here, this is a bit more encouraging. So the normal numbers looking across, while there's no standard defined minimum requirement, most countries go for one nurse to 3 to 4 beds, which is the same for across most regions, except from Ariha, where you have 1 nurse per 10 beds. Ariha, is important to acknowledge, is also the place where most of the ceasefire violations has occurred. So this is a place of high need for trauma care. So looking at the future, this is a bit more of a worrying picture. We find that actually the numbers in training is much lower, and that's across the districts. there's very few surgeons, anaesthetists and obstetricians, residents or trainees. And the same goes for nurses, very fewer numbers, and that's something that certainly warrants further input.
So in summary, our preliminary survey findings suggest that there is limited surgical provision, limited anaesthetic capacity, and there is a limited workforce and skill set. We've shown that the surgical services and health networks across Syria are fragmented, and there seems to be a limited capacity to perform bellwether procedures and safe anesthesia as per WFSA guidelines. I think it's important to note that, for example, critical emergency procedures, for example, vascular stabilization when dealing with a bleeding patient, it's only available in about 42% of facilities. And importantly, these cases are referred because of a lack of supplies, 81%, but 94% due to a lack of skills. We also conducted a workshop, as alluded to earlier, and I think many of the themes were explored in previous speakers' presentations. But what it paints a picture of complex challenges and the system having to adapt quite rapidly to changing security circumstances, as well as COVID, for example. What we found was that, for instance, transport is a massive barrier to patient access to healthcare, where fuel costs are about 20 times higher than the daily living wage. Staff reported a risk of burnout with 48-hour-long shifts, lack of support from management, for instance, and a feeling that they're unable to really change the system. There's also a lack of governance, and there's a complex mosaic, as alluded to in earlier presentations, of NGOs and other actors supporting and running these hospitals and facilities. Security is an ever-present issue, with hospitals and medical facilities being actively targeted. And so these resources have to move to safer areas, leaving vulnerable areas with less healthcare. Systems have adapted, though. For example, the on-call system in many of these facilities are designed to prevent staff having to travel home at night when it can be more dangerous. There are also informal social media networks to warn staff of any impending attacks, and they monitor conflict frontline areas. There's also a referral network, which is both mixed, formally and informally, and patients can self-refer as well. But we hope to explore this in a lot more detail because we are in the future.
So very briefly on the limitations. So of course, the health facilities that didn't participate, we don't have their data, and therefore that might skew the picture slightly. But thankfully, we have really good coverage in quite a few of the districts to at least have a full picture there. This is only a preliminary view. As Hussain mentioned, there is a lot more variables that we need to explore, and we need to get a better picture how some of these things correlate between. I think it's important to acknowledge that workforce-wise, some staff may have been counted multiple times. This may produce an overestimation of human resource, while at the same time there's some task shifting, which may mean an underestimation of services offered. But this is something that we'll take into consideration. And then just on the last slide, so we'd like to acknowledge loads of people, both the people assisting with the workshop, all the people supporting on the ground, and then of course the people who've been part of this from the start in terms of developing the survey and what's to come in terms of the analysis down the line. We've left a couple of QR codes here. If you'd like to see the survey and explore it and have a play through it, then please use the QR link there. And all the references are available through that QR code on the other side on the left. Thank you very much.
Thank you.
Thank you. I mean, not only for an interesting and very important topic, but also for the collaboration and harmonization of the presentation that you've got, which also reassure that we can work really smoothly and really nicely together. I think that we have some questions from the attendees. I'll start with the question that is for you guys from Amina. So she's saying, thank you for a very interesting presentation. Did the facilities included in the study include private facilities, e.g. when it comes to the referrals?
I will jump in and try to answer. Thank you very much, Amina, for this important question. Actually, the data that we collected included public hospitals and charity hospitals who agreed to participate. I don't believe we had access to private facilities, like private hospitals, although like we know that the number is very small in northwestern Syria. Of course, this is different in other parts of the country, but these are not covered in our survey. Mainly, I'm talking here about the Northeast.
Thank you, Hussam. The other comment or question on your study is from Omar. He's saying the problem is the structure of the health system in northwest Syria. The hospitals were established and categorized according to specialization into surgical hospitals, obstetrics and gynecology hospitals, children's hospitals, etc. So this means that it's possible to find many hospitals that provide complete surgical services but don't provide obstetric services and cesarean sections, and in case of women's injuries, they are forced to transfer to other centers. This is a significant surgical issue. I don't know if you do have any comments on that. Thank you, Omar.
Yeah, no, absolutely. I mean, this is what we found as well when we look at the more granular data on especially those bellwether procedures, that there is a fragmentation of surgical services and specialization. So yes, it certainly is a concern in this current context.
Yeah, thank you.
I can quickly just add a comment on this. We know that for security reasons, hospitals are like hesitant to have all these services available in one place because of the vulnerability for being targeted and like the susceptibility for being destroyed. Still, this have direct impact on the quality of care. One of the cases or examples that we got during the workshop is like a case of a woman with a GI bleeding that she had to travel between 5 different hospitals to get the care she needed, and also to be admitted in a surgical ICU to get this care, which is like, we can understand this security concerns, but at the same time, we need to make this balance between like the safety of the staff and patients, but also the quality of services.
Exactly. Thank you. Thank you, Hussam, and everyone. The next question is from Mirvat Al-Haffar, and I think it is to Sarah. So the question says, thank you for all presentations. My question is for Sarah on what are the pitfalls to reproduce the concept of primary healthcare in the Syrian conflict?
Yeah, thank you very much for the question, Marva. It's really interesting. So I would say in terms of reproducing the concept of primary healthcare, so primary healthcare, there has been a primary healthcare system in Syria even before the conflict. So I wouldn't say it's as much of an issue in terms of reproducing the whole system. I think it's probably developing it a bit further and ensuring that it's used appropriately. And so I think from our study, some of the things that we found was like very heavily to do with the cultural impressions of primary healthcare. So in terms of actually trying to recruit doctors to work and other healthcare workers to work in primary healthcare is a challenge, because people see it as kind of the bottom of the barrel, you know, the worst thing that you could do. And so there is a challenge in recruitment. And then in terms of utilization, I think, again, because although there was a primary healthcare system before in place, it didn't function ideally. And so I think the impression that a lot of the public have of primary healthcare is really negative. And so that reduces their value of it. And so then the way that they use it isn't always appropriate. And so I think those are some of the really big challenges that need to be addressed. But obviously, contextually, there's difficulties in terms of investing and building infrastructure to develop a primary healthcare system when, you know, there's the risk of it being bombed and destroyed very quickly. So yeah, so I would say there's a lot of challenges in developing it further, but there is a primary healthcare system in place. It just needs to be worked on, I think. I don't know if that answers the question or not, but hopefully that was okay.
No, I think that's fairly put, because, yeah, I mean, the main thing is the research can do is that just highlight what the statute is now and then, where we need to work further. And maybe that would be another question for another research. I think we have another question from Dr. Munder about the distribution of health facilities relied on a security strategy primarily to protect medical personnel and medical work. Therefore, large health facilities appeared in border areas far from being targeted. So it's just, I think it's trying to like talk about why the situation is like that. I do have one question to Ms. Agneta, if she's here, actually, on how to preserve the motivation of healthcare workers inside Syria. So we knew that there are some motivation, and with time we think that this motivation would fade out, especially if they would compare their incentives compared to those who left. So how, I'm not sure if the research has covered this, how we can work more on making more incentives and motivation to keep this workforce in place, but I'm not sure if she's with us.
I'm here. Sorry for the inconvenience. That is a really good question, and our research actually doesn't cover that. But I think the main issue is the security. If we cannot give the security, the motivation to provide healthcare services, even if you feel that you feel strong for your country, but many of those participants, they had families and they kept their families safe in the Turkey and went to the Syrian side. But I think that if we cannot guarantee the security for them, then how can we find the motivation for because we need more doctors in Syria. So those were the persons who had motivations and they were willing to risk their life. But I know that there are many that don't want to do that, and it's obvious that not everyone wants to do that.
So the final question, because I'm aware of the time, we do have now a 30 minutes, maybe 25 minutes lunch break, and then we will continue on at 12:15. So the final question is from Ahmed Haboush, is saying, thank you very much everyone for the brilliant presentation. Commenting on Dr. Sar's presentation, I believe trust of the community is key to optimize primary care structure. In our views, what type of evidence could help to increase the community and the key stakeholders buy-in?
Yeah, I mean, I completely agree with you. I do think it is definitely key. I think so. From a lot of what was discussed in the interviews and what kind of came out, the main things in terms of the public was just really increasing education. But I mean, holistically in terms of increasing education generally, but specifically in terms of healthcare, just trying to make people aware of the specific system. So how to make use of the system. So you should go to primary healthcare first and then secondary, rather than jumping straight to secondary, or just assuming that primary healthcare is going to be the same as secondary healthcare. So I think increasing education around that, it probably would make the biggest difference. And obviously looking at how to do that in the best way possible, whether that's through social media or in-person sessions, or so evidence around that would be very useful. For healthcare workers, there was a lot of emphasis placed on improving like job security, increasing salaries, trying to balance the value placed on primary healthcare and other specialties through like monetary value through salaries and things like that. So probably again looking at doing further research, looking at whether what maybe medical students specifically or junior doctors, what they think about primary healthcare, what would motivate them to follow, to pursue a career in primary healthcare, and if certain factors would change their ideas or their impression of it, I think would probably be useful to look at.
Thank you, Sarah. Thank you, everyone, for the presentations, the great presentation that you did for attendees. And just a reminder that one of the main goals of this conference is to connect people together. So I'm sure that you have like mutual interest and you can connect together, and maybe that would like result in more collaboration and more work together. Just a reminder that we now have a break and we shall continue at 12:15. Thank you, everyone.
Thank you.